We designed appropriate empiric therapy for HAP and VAP. Now, given microbiological results, let's de-escalate from empiric therapy to pathogen-directed therapy. In general, there are a lot of different types of bacteria, and they could be part of the normal flora, so they are actually essential for the normal human health, or they could be colonized, which means that bacteria that are not part of the flora could actually be in part of like the GI tract, for example, and not necessarily cause an infection and just colonize it. Now, whether colonized or as part of normal flora, bacteria occasionally can have resistant genes. So let's say the red bacteria here are resistant to antibiotics and the blue ones are susceptible. And keep in mind that this is just part of the flora, not necessarily an infection. Now, what happens every time that we use antibiotics is that the antibiotic, while we use it to treat an infection, what it does to the actual flora is that it actually wipes out all the ones that are susceptible to that antibiotic, and the ones that are resistant to that antibiotic will stay behind because the antibiotic could not kill it. Now, again, those bacteria were not really causing an infection, they were just part of the flora. But when we use the antibiotic, we actually selected for them, and now they have the opportunity to become the dominant bacteria in the flora. Or if they were just a colonization, now they become the dominant organisms in the body. And keep in mind that they all have the genes for resistance to antibiotics. Now, occasionally, if someone gets actually infected, what happens is that these bacteria that have the genes, the resistant gene, they can actually transfer it. So they can donate that gene to a pathogen, which will cause drug-resistant infection. This whole process is referred to as selection pressure. Which brings us to the concept of broad versus narrow spectrum of activity. So generally speaking, broader antibiotics are more likely to cause selective pressure because they can wipe out more clinically significant organisms and leaving behind the resistant organisms. Now, when it comes to broad versus narrow, the generally accepted definition is based on gram-negative coverage. It's not so much about a head count, so it's not about how many organisms an antibiotic covers. It's more about which organisms does it cover. So it's about clinically significant organisms. So in order to understand if a drug is broad or narrow, you should ask yourself the following question. Does it cover carbapenem-resistant Enterobacteriaceae? Now, CRE, such as E. coli and Klebsiella, that are resistant to carbapenems, we don't have a lot of antibiotic options for them. So this is one of the most resistant pathogens available. So if we have antibiotics that's active against CRE, we should reserve it for CRE. So this is considered the broadest class of antibiotics. The next question you should ask yourself is, does the antibiotic cover multi-drug resistant Pseudomonas? If so, it is very broad and it should be reserved for multi-drug resistant Pseudomonas. Another question to ask is, does it cover Pseudomonas period? Because Pseudomonas can select for resistance very quickly, if you are not treating Pseudomonas, you should not be using a drug that's active against Pseudomonas if possible. And the next question is, if a drug covers ESBL Enterobacteriaceae, it should be reserved for ESBL organisms if possible. And lastly, if a drug is more likely to disturb the gut flora and lead to Clostridioides difficile infection, we should use an alternative if possible. Now, in order to help you understand broad versus narrow, I have created a tiering system, which is by no means an official way. It's just a way of helping you understand broad versus narrow and give you a visual reference. So at the top of this pyramid, we have the narrow. So tier 1 or antibiotics such as cefazolin and trimsulfa or trimethoprim sulfamethoxazole are pretty narrow because they typically cover protease, E. coli, and Klebsiella. Again, this pyramid is strictly based on gram-negative coverage. So it is not considering gram-positive organisms, it is not considering atypical organisms, and it is not considering anaerobes. So the next tier covers Protease, E. coli, Klebsiella, but also Haemophilus and Neisseria. So in tier 2, we have third generation cephalosporins such as ceftriaxone. And then the next tier adds what we refer to as CAPE. So Citrobacter, Acinetobacter, Providentia, Enterobacter, and Serratia organisms, as well as ESBL organisms. So this is ertapenem. Ertapenem is the only carbapenem that does not cover Pseudomonas. So because it does not cover Pseudomonas, it's considered the narrowest carbapenem, and I have put it in tier 3. And then in tier 4, that's when we start to get broad, because now we have coverage for Pseudomonas aeruginosa. So in tier 4, we have all the antibiotics that cover Pseudomonas. So ciprofloxacin, levofloxacin, aminoglycosides like gentamicin, tobramycin, cefepime, piperacillin, tazobactam. And then on the next tier, not only do they cover Pseudomonas, but also they cover multi-drug resistant Pseudomonas. So multi-drug resistant Pseudomonas is the type of Pseudomonas that would be resistant to tier 4 antibiotics. So that's when carbapenems come in. So meropenem, imipenem, and also ceftolozane and tazobactam, they are usually active against multi-drug resistant Pseudomonas. So they are broader than tier 4. And then now we get to the broadest tier, which is the antibiotics that actually cover CRE. So because CRE is one of the most resistant organisms, we should reserve these for CRE. So ceftazidime avibactam, meropenem vaborbactam, polymyxin B, colistin, amikacin, and plazomycin, they all have good activity against CRE, and they should be reserved. And then I also added a tier 7, which is also active against CRE, and we have tigecycline and eravacycline. And the only reason I broke tier 6 and 7 differently is just to show you that tigecycline, while it is extremely broad, it does not cover Pseudomonas. So it's actually lacking Pseudomonas and multi-drug resistant Pseudomonas, but because it's active and it's used for CRE, it's considered very broad. So, you can bundle tier 6 and 7 together, but it's important for you to understand that this tier 7 actually does not cover Pseudomonas. So when we de-escalate, if, whether you are on tier 5 or 4, every time you get susceptibility results back and we can go to narrower options, we should. So that's what the guideline is recommending. So when it comes to gram-positive, we discussed the risk factors for MRSA. So empirically, you will have an agent like vancomycin or linezolid for MRSA. And once the culture and susceptibility results come back, and if it is MRSA, then we continue vancomycin, and then you can discontinue the antibiotics for pseudomonal coverage. Alternatively, if the results come back and it is not MRSA and it is MSSA, then you should discontinue vancomycin and start the patient on oxacillin or nafcillin or cefazolin, because these are, tier 1. These are tier 1 or antibiotics, and you should discontinue any other agent for Pseudomonas. Now, if the patient actually happens to have Pseudomonas, then you should use the results of antimicrobial susceptibility to see which one is susceptible and use it. Now, generally speaking, only one agent is sufficient when it comes to pathogen-directed therapy. Occasionally, you can use 2 agents if the risk of death is high in the patient. For example, septic shock would be an example. So if a patient is still in the ICU on pressors, in order to maintain normal blood pressure, that patient could benefit from 2 agents, even for definitive therapy. Again, it's important to avoid aminoglycoside monotherapy. Even if Pseudomonas is susceptible to aminoglycoside, you should not use aminoglycoside monotherapy. You can only use aminoglycoside as a part of a combination. So, for example, you can use aminoglycoside plus cefepime. Now, when it comes to multi-drug resistant pathogens, you can also add inhaled therapy. So one of the problems is penetration to the lungs. So if it's difficult for many of these antibodies to actually get to the site of infection, so inhaled therapy will actually deliver the antibiotics to the site of infection, which is the lung. But inhaled therapy should never be monotherapy. It's always an add-on. So you add it to your IV therapy. So if someone is getting cefepime and IV tobramycin, and you can add inhaled tobramycin on top of it. So inhaled tobramycin is not to replace IV tobramycin. And lastly, if you do have a ESBL agent in the lungs, the guideline doesn't make a specific recommendation, so you can use anything that's susceptible. Now, historically, we have said that carbapenems are drug of choice for ESBLs, and it has been subject to some controversy in recent time. Recently, there was a study, the Merino study, that showed that when it comes to bacteremia, carbapenems are better than piperacillin and tazobactam because it reduces mortality. So my recommendation is to also use carbapenems for pneumonia. But basically we have limited data when it comes to pneumonia with ESBLs.